Okay, Ji. Now my topic, as Dr. Yahya has told, is anesthesia plan for thoracic surgery. I have no conflict of interest to declare, except AI tools were utilized solely to assist in the preparation and organization of this presentation content. Now, this is an AI-generated case scenario in which a patient, Mr. Ahmad, of 75 kg, 65 years of age, is scheduled for lung resection for non-small cell lung carcinoma. His comorbids include COPD with EF of 50, FEV1 of 55%, DLC of 50%. He is hypertensive, history of coronary artery disease, and heavy smokers. His vitals are within normal limits. His airway assessment revealed normal airway. Now, the operability roadmap will be the functional assessment, which will determine baseline mechanical, parenchymal, and cardiopulmonary result. Then risk stratification by applying European Respiratory Society and European Society of Thoracic guidelines of 2025 to define the specific perioperative risk. Then the system optimization, that is, we will optimize the modifiable risk factors, that is smoking and cardiovascular status. And at the end, we will formulate intraoperative and postoperative management plan. Why is risk assessment is important? It is important to detect patients who are at high risk of perioperative respiratory complication, that is atelectasis, pneumonia, and respiratory failure. Their incidence is about 10 to 15% after surgery. And number two, to deploy appropriate optimization protocols before surgery to reduce risk. And then ensure post-operative resection result, that is to ascertain there will be sufficient result to keep the patient comfortable and prevent respiratory crippling. And evaluate tolerance, assess for pneumonectomy, even if planned procedure is lobectomies or wedge resection. Now, the thoracic assessment relies on three distinct pillars. Number one is lung mechanism, which is measured by a force expiratory volume in 1 second. The other one is lung parenchyma, which is measured by a diffusing capacity for carbon monoxide. Third one is cardiopulmonary interaction, which is measured through exercise testing and VO2 max. The golden rule is that absolute values do not predict outcome. The absolute value of FEV1 depends on height, age, race, and sex. The gold standard is that the predicted post-operative percentage of the reference value using the best post-operative bronchodilator result. Regarding first pillar, calculating functional lung result, there are two formulas. One is the anatomical method, which is standard for lobectomies, in which predicted post-operative value of FEV1 or predicted post-operative value of diffusing capacity for carbon monoxide is measured. In this formula, the preoperative percentage value is multiplied by 1 minus number of segments removed, but divided by total segment, which is 19. As you can see, there are total 19 segments, 9 on the left side and 10 on the right side. In this patient is scheduled for dissection of these 3 segments, that is right upper lobectomy. So we can calculate post-operative predictive FEV1% by multiplying its pre-operative value of 55% with 1 minus 3 over 19. 3 are the segments which will be removed and 19 are the total segments. So the predicted post-operative FEV1 will be 47.1%. When we compare with the ERS 2025 guidelines stratification, patient will be at moderate risk because his value is between 40 and 59%. The other formula is functional method.
Sorry, sir. I am sorry to interrupt you, sir. Sir, we have a small issue. Some of our participants can't see your screen, sir.
I don't know why.
स्क्रीन तो नजर सबसे फुल स्क्रीन पे भी है जो लोग मोबाइल पे अटेंड कर रहे हैं शायद प्रॉब्लम उनको आ रही होगी।
जी सर, बिल्कुल।
जी मैं मोबाइल पे हूँ लेकिन कोई इशू नहीं है।
अच्छा, लैपटॉप पर भी प्रॉब्लम आ रही है?
लैपटॉप में भी नहीं आ रही
सर लैपटॉप पे हमें तो आ रहा है नजर। आई डोंट नो व्हाई।
कुछ को आ रहा है तो फिर जिनको नहीं आ रहा प्रॉब्लम उनमें यहाँ से
डॉक्टर इम्तियाज, आप एक दफा स्लाइड शेयरिंग ऑफ करके दोबारा ऑन कर लें।
हाँ ये कर लें, अगर दफा ऑफ करके ऑन कर
ऑन कर लें।
अच्छा ठीक है।
यहाँ से आप फुल स्क्रीन मोड पे जाके फिर देखिएगा।
अच्छा, मैंने स्टॉप शेयरिंग कर दी है। आई एम शेयरिंग अगेन।
शेयर अगेन एंड गो टू फुल स्क्रीन।
ओके सर। Now is it visible?
No.
Yes, हाँ ठीक है।
जी बिल्कुल।
Yes, sir, it's visible.
ओके जी।
No, but it's not visible to us.
कहीं इंटरनेट कनेक्शन का मसला तो नहीं है कि आपके पास वीडियो जो है वो नहीं आ रही?
लास्ट प्रेजेंटेशन की तो आ रही थी
सर इंटरनेट चेक करें, वैसे सबको नजर आ रही है स्क्रीन। ये
जी साहब देख लीजिएगा क्या प्रॉब्लम है।
जी सर।
हमारे पास तो स्क्रीन नजर आ रही है इस वक्त।
जी सर, प्लीज कंटिन्यू। मेरे ख्याल में आप वहाँ चेक करवा लेते हैं, इंटरनेट सर के पास से मे बी इशू हो।
Should I continue?
जी डॉक्टर इम्तियाज कंटिन्यू करें।
Okay, thank you. The second method is functional method, which is reserved for pneumonectomy or borderline cases. This method is used when functional unobstructed lung segments are unknown, requires a split function ventilation perfusion scan. So preoperative percentage value in this case will be multiplied by 1 minus fraction of total perfusion for this resected lung is equal to the predicted post-operative value. Now moving to the second pillar, that is parenchymal function, calculating predicted post-op DLCO. It has the same formula in which baseline DLCO, which is 50%, is used, and predicted post-operative value of DLCO is found out. And this baseline DLCO is multiplied by 1 minus segments removed divided by total segments. So 50 multiplied by 1 minus 3/19, the value will come out to be 42.8%. So this patient has narrowly cleared the high-risk cutoff of less than 40% for respiratory post-op respiratory complications. His borderline parenchymal function, that is 48.8%, mandates closed scrutiny and force the progression to third pillar. In past, ABGs were also used to find out the preoperative PO2 and PCO2. If PCO2 was above 45%, then patient was considered high risk for surgery. According to 2025 ESTS mandate, predicted post-operative DLCO is an essential preoperative step if FEV1 or DLCO are impaired. It is highly predictive of both respiratory and cardiac complications independent of FEV1. Now, the third pillar is cardiopulmonary interaction. In this step, evaluation of the patient exercise capacity is measured. After clinical history, patient is subjected to some exercises like stair climbing threshold, and if patient can climb 2 flights of stairs, his metabolic equivalents is approximately equal to 4 METs. If his metabolic METs are less than 4 but more than 2, then patient is subjected to field test or 6-minute walk test. During this test, patient will have to cover some distance. The cutoff value is 400 meters. If he can cover above more than 400 meters, he can proceed for surgery. If it is below 400 meters, then next step is cardiopulmonary exercise testing, in which VO2 max is calculated. If VO2 max is more than 20 ml per kg per minute, patient is safe and low risk for surgery. If VO2 max is less than 15 ml per kg per minute, patient will be high risk, and VO2 max of less than 10 ml per kg per minute, patient will be extremely high risk, and alternate treatment will be offered other than surgery. VO2 max of more than 20 ml per kg per minute will make the patient fit for pneumonectomy. VO2 max of more than 15 ml per kg per minute will be required for fitness of lobectomy. VO2 max of less than 10 ml per kg per minute, patient will be unfit for lung resection. Now, this is operability algorithm for lung resection. In preoperative respiratory evaluation, functional capacity of patient is measured. If it is less than 2 meds, then patient will be referred for medical consultation and optimization. If functional capacity is more than 2 meds but less than 4 meds due to COPD or coronary artery disease, we will do spirometry to find out the predicted value of predicted post-operative FEV1 and predicted post-op DLCO. If the value of these two is more than 60, patient will be fit for surgery, and either if it is less than 30, patient will be subjected to cardiopulmonary exercise testing. But in this case, our patient has predicted post-operative FEV1 value of 47.1% and DLC of 42.8%. So he lies between 30 and 60%. We will have to do simple exercise tests that like 6-minute walk test. If his distance is less than 400 meters, cardiopulmonary exercise testing will be done. In our case, his distance was less than 400, so cardiopulmonary exercise testing was done. And Mr. Ahmad, VO2 max was more than 15 ml per kg per minute, making him fit for surgery. Now, there is a surgical paradigm shift from open thoracotomy to VATS. In open thoracotomy, increased respiratory rate threshold begins at less than 40%, while in VATS or minimal invasive surgeries, increased respiratory rate threshold shifts toward the 30%. So increasing the safety margin in cases of minimal procedures. This means patients previously considered high risk for open thoracotomy, like Mr. Ahmad, at the predicted post-operative FEV1 value of 47.1% will fall in safe limits when VATS or robotic approaches are utilized. Now, evaluation for cardiovascular risk factor. There are the threat files in this patient are procedure risk. Lung resection is intermediate risk procedure for 10 to 15% complication rate. Secondly, patient is a geriatric patient with an age of 68 years, documented coronary artery disease and hypertension. So this patient is specifically vulnerable to post-operative or intraoperative arrhythmias, particularly atrial fibrillation. Now, ESTS 2025 action plan in this case will be, first we'll do 12-lead ECG to find out any positive findings. Second step will be cardiology evaluation, and third step, first level assessment is by echocardiogram due to documented coronary artery disease before surgical clearance. Now, doing cardiovascular evaluation according to past history of patient has history of chest pain, cardiac workup was done, angiography revealed non-obstructive coronary artery disease, which was managed medically and continued on medical treatment, and patient was optimized on medicine. Present history and examination has no active cardiac disease, ECG has no changes, echocardiogram showed normal biventricular function with no renal valve motion abnormalities. So patient is low to intermediate perioperative cardiac risk for elective thoracic surgery. No additional preoperative cardiac testing is required unless new symptoms develop. Patient is optimized. Patient hypertensive disease is also optimized medically. Now the third factor is age. Older age does not mandate impact surgical outcomes. Older age does not independently impact surgical outcome, that is morbidity, mortality, and survival when patients are properly selected. This means frailty ranks second in overall relative importance for determination of his high risk in lung cancer patients. So chronological age should not be measured, rather physiological age should be assessed by using frailty phenotype scale. So Mr. Ahmad, you cannot be declined on the basis of age only. after implementing Freud's frailty phenotype screening scale when mandated for more than 60 years of age. Regarding perioperative smoking cessation and optimization, smoking should be stopped more than 4 weeks before surgery to gain significant reduction in major pulmonary complications and improve ciliary clearance. But even if it stopped on the day of surgery and continued to stop for 1 week post-operatively, there will be reduction in wound infection, as current smokers have 2.15 higher wound complication risk. If smoking is stopped 12 hours before surgery, carboxyhemoglobin concentration will drop, shifting oxyhemoglobin curve to right, increasing tissue oxygenation. The insight is there is no rebound increase in secretion that contraindicates short-term cessation. So every hour counts. Defining the high-risk surgical candidates. According to ESTS guidelines, presence of one absolute risk or two relative risks may make the patient high risk. So other treatment modalities will be considered except surgery. Surgery will be deferred and non-surgical alternative will be offered to the patient. Absolute risks are 4. 3 are known to us. This is ventilation, minor ventilation, CO2 production slope above 40 means that this test is measured during cardiopulmonary exercise testing. This test shows that how much carbon dioxide is removed from the lungs during 1 minute. If slope goes upward toward the 40 level, this means minimum CO2 is removed and ventilatory efficiency is not good. If slope is lower, that is toward 30 or 35, this means there is good CO2 exhalation. Relative risks are predictive post-operative DLCO less than 40%, VO2 peak less than 12 ml per kg per minute, stable interstitial lung disease, impaired performance status, ECOG scale more than or equal to 2. This is Eastern Cooperative Oncology Group Performance Scale. This scale look at the performance of patients with lung cancer. They look their prognosis and their activity. This scale starts from 0 to 3. 0 means patient is active, mobile, and functional. As this scale goes up, the functionality of the patient reduces. At the scale of 2 or more, patient 50% time is passed in bed, and 50% time he is mobile, but is 50% time is passed in the bed. The final decision for our case, the patient is considered appropriate candidate for right upper lobectomy via VATS approach with an estimated low to moderate risk for perioperative cardiopulmonary complications. Now, important intraoperative monitoring during this case will be routine monitoring with precordial or esophageal stethoscope use to find out the lung respiratory movements and to monitor the double lumen tube position. Apart from these, invasive arterial blood pressure will be monitored to find out the beat-to-beat blood pressure and ABG monitoring for ABGs. Central venous line should also be considered in this case because he had history of coronary artery disease, and if it should be passed at induction, and if it is not passed, then patient will be turned to the lateral position, and if required intraoperatively, it will be difficult to pass CVP. And similarly, pulse oximeter, arterial blood gases should be monitored because there is chances of hypoxemia in this case because the right lobectomy is being done. Other monitorings are capnograph monitoring and ventilatory parameters like tidal volume, minute ventilation, plateau pressures, respiratory rate, peak airway pressures, and PEEP should also be monitored. Now, airway and ventilation. Anticipating the difficult thoracic airway is very important. As routine predictors are amplified, double lumen tubes which will be used in this case are larger and stiffer than standard ETTs. Baseline difficult airway becomes significantly more challenging. Prior surgical history, prior pulmonary resection, tracheostomies, or airway trauma alter the normal internal anatomy. Tracheal bronchial anatomy should also be assessed by reviewing chest X-ray, CT scan, or tracheal to find out tracheal deviation, coronal distortion, or endobronchial tumor invasion that may prohibit double lumen tube placement. Mediastinal masses, anterior or superior masses present a catastrophic risk for total airway collapse upon induction of general anesthesia. This patient will definitely need one lung ventilation, as absolute indications are prevention of contamination, control of ventilation, and urinary lung lavage. In this case, VATS is the procedure. There is absolute indication for one lung ventilation. On relative side, upper lobectomy is planned, so relative indication of high priority is there. Methods of lung separations include double lumen endobronchial tubes, bronchial blockers, univent tube, endobronchial intubation with a single lumen tube. Optimal device for this patient will be left-sided double lumen tube of 39 French. Left-sided double lumen tube is mostly used. It provides reliable lung isolation, allows independent ventilation of each lung. It facilitates suctioning of secretions, permits CPAP application to the non-dependent lung. Now, about calculation of size of double lumen tube, it can be based on sex and height. For example, females with less than 160 centimeter, 35 French size double lumen tube will be used, and females of more than 160 centimeter, 37 size double lumen tube can be used. In males less than 170 centimeter, 39 French tube can be used, and male more than 170 centimeter, 41 size French size double lumen tube can be used. For females of short stature, less than 152 centimeter or 60 inch, examine bronchial diameter on computed tomograph and consider 32 French double lumen tube. For males of short stature that is less than 160 centimeter, consider 37 double lumen tube. Now, regarding one lung ventilation, protective strategy is used in one lung ventilation. So, tidal volume of 4 to 6 ml per kg ideal body weight to prevent value trauma in the dependent lung. PEEP will have to be used because on low tidal volume, there is high chance of atelectasis. So, titrated PEEP should be used to maintain FRC and prevent atelect trauma. But as this patient is a COPD patient, PEEP should be used cautiously as there is a increasing risk of intrinsic PEEP or hyperinflation requires careful monitoring. FiO2 should be treated according to SpO2 to avoid absorption, atelectasis, and oxidative stress. Routine recruitment maneuver should be used to minimize injury to the ventilated lung and to prevent atelectasis, as atelectasis is more dangerous than high tidal volume for recruitment maneuver. Insight is that hypoxemia during one lung ventilation is now infrequent due to modern low dose of volatile anesthetics or TIVA techniques that preserve hypoxic pulmonary vasoconstriction. Now, intraoperative fluid management in this case. Perioperative quality initiative consensus guidelines suggest that buffered crystallite solutions like plasma light and ringers should be the first line choice due to their high efficiency, renal safety, low chloride load, POQI standard of care in the absence of hypochloremia. Normal saline should be avoided in routine use due to high chloride load, significant risk of hyperchloremic metabolic acidosis, and renal vasoconstriction leading to acute kidney injury. Synthetic colloids should also be avoided. They are not recommended due to high risk of acute kidney injury and coagulopathy. No proven mortality benefit over crystalloids in the thoracic settings. Albumin is also not recommended routinely. It is equivalent to the crystalloids in outcome. It has high cost with no specific advantages demonstrated for one lung ventilation specifically. There is a colloid myth. While only 1/5 of the crystalloids remain intravascular, colloids show no outcome superiority in thoracic cases. The evolution of fluid strategies in thoracic surgery. In past, liberal strategies were used. These were formula-based fixed, and fluid was administered to all patients at the rate of 8 to 10 ml per kg per hour, so not matching the individual physiology. This resulted in unacceptable rates of ARDS and pulmonary edema. Recent restrictive lung strategies include fixed low-volume administration of 2 ml per kg per hour to protect the lung at all costs. Result reduced lung injury, but increased hidden acute kidney injury risk from hypoperfusion. Current trend is focused on goal-directed therapy. Individualized therapy fluid. It is individualized therapy. It is based on fluid administration only when dynamic indices predict a stroke volume increase. But the question is, does goal-directed therapy actually work in the altered physiology of thoracic surgery? The answer is, in case of general surgery, is ideal for pulse pressure variation. In general surgery, there is a closed pressurized chest, supine position, tidal volume used are at 8 ml per kg. So there is strong pressure challenge. In case of thoracic surgery, there is open chest. So open chest cause dissipation of intrathoracic pressure variation. Lateral decubitus position cause gravitational pulling of fluids and alters the return. Protected lung ventilation has low tidal volume, that is 6 or less than 6 ml per kg body weight, do not generate enough pressure to test the fluid responsiveness. So the confining factor is surgical manipulation, also frequently cause arrhythmias, invalidating beat-to-beat pulse pressure variation. Pulse pressure variation needs sinus rhythm. The oliguria dilemma, lung versus kidney protection, results in transient targeted normovolemia, results in transient benign perioperative oliguria, highly protective of the dependent lung. But some people chase the urine output. There is aggressive fluid loading to force the urine output more than 0.5 ml per kg per hour, predictably causing fluid overload and ARDS. The clinical evidence is that restrictive and near zero thoracic fluid protocols frequently cause intraoperative oliguria. However, registry data definitely shows this transient state is not associated with increased post-operative acute kidney injury. So do not aggressively fluid load a stable thoracic patient in a fixed or urine number. Evidence-based pathway pre-op and intra-op. Allow patient to take clear fluid up to 2 hours pre-op, so maintain physiological hydration. Do not start the case behind on fluid levels. Restrict basal rate. Follow the strict basal rate, that is 2 ml per kg per hour of buffered crystalloid solutions like plasma light and lactated ringers. If MAP drops less than 65 millimeter of mercury, primary action should be uncouple blood pressure from fluid therapy. Administer vasopressors early, for example, ephedrine and norepinephrine should be used. Secondary action should be administer fluid bolus only if there is a confirmed absolute hypovolemia or massive blood loss. Now, extubation can also be planned on predicted post-operative FEV1 value. If it is more than 40%, patient can be extubated in operating room. Patient should be alert, warm, and comfortable. If it is between 30 and 40%, consider extubation based on exercise tolerance, DLCO, VQ scan, and associated diseases. Less than 30% stage weaning should be done. Stage weaning from mechanical ventilation should be done. Consider extubation if value is more than 20%, and there should be epidural analgesia to relieve the pain. This is not a fixed criteria. Extubation can be done according to the circumstances, and doing ABGs and looking at the ventilatory parameters and patient condition. Now, evidence-based pathway post-op and ERAS protocol. The first 24 hours of post-extubation present peak risk for acute lung injury and pulmonary edema. POQI consensus recommend against a positive fluid balance in the first 24 hours following lung resection surgery. According to ERAS protocol, initiate early enteral intake, discontinue maintenance IV fluid immediately upon adequate oral hydration. Now, post-operative analgesia, most important component of thoracic surgery. Now, thoracotomy triggers 5 distinct nociceptive afferent pathways. First is incision site, which take away the nerves which take the pain cessation are T4 to T6. Second is chest drain. Nerves involved are T7 and T8. Third site is mediastinal pleura. The pain sensation is taken by vagus nerve. And fourth place is diaphragm, and the phrenic nerve takes the pain sensation, that is root value C3, C5. There is a ipsilateral shoulder pain, which is rapid pain, and also brachial plexus can carry pain sensation. So there is no single modality which can cover all these 5 nociceptive sites. Epidural cannot cover phrenic nerve and rapid pain and vagus nerve transmitted pain. So we need multimodal therapy to cover all these sites. The Tri-8 for post-thoracotomy pain management are local anesthetics, which obliterates the osmotic pain at the incision and drain side via epidural, paravertebral, or facial fan blocks. Second is anti-inflammatory drugs. These are critical for addressing visceral and rapid shoulder pain, phrenic, vagus nerve origins that evades neuroaxial and chest wall blocks. Third are the opioids. They are effective for background pain control. However, escalating doses of the opioids can lead to respiratory depression and cough suppression, leading to hypoventilation and sedation. So doses must be minimized. Oral and intravenous non-opioid formulations include acetaminophen. Those up to 4 times per day can be used. Highly effective for ipsilateral shoulder pain. Low toxicity profile compared to potent COX inhibitors. Now, NSAID and COX inhibitors, they reduce opioid consumption by more than 30%, excellent for rapid shoulder pain. But there is critical warning routinely withheld in patients who recently received cisplatin chemotherapy due to compound risk of severe renal toxicity. Gabapentin's role in acute thoracic pain remains unclear. Preoperative administration shows no distinct benefit when combined with epidurals, may benefit patients relying solely on IV morphine. Now, advanced systemic infusion intercept escalating pain. These include ketamine, given in infusion form in doses of 0.1 to 0.515 milligram per kg. This sub-anesthetic NMDA agonism is excellent for acute pain reduction. The warnings that their psychomotor effects are rare at this dose. Unclear benefits for chronic pain. Dexmedetomidine is excellent drug. This can be used in 0.3 to 0.4 microgram per kg per hour. It is potent alpha-2 agonist, decreases opioid requirements, and preserves renal function. There is risk of hypertension and require careful titration and monitoring. IV lidocaine in doses of 1 to 2 milligram per kg per hour. It act by systemic sodium channel blockade. Current evidence shows mixed, unreliable results specifically for post-thoracotomy and VATS pain. Selecting optimal renal analgesia technique. Coverage area in case of thoracic epidural is bilateral. In case of paravertebral block, unilateral and somatic. In case of erector spiny block, unilateral, somatic, and visceral. Serratus anterior plan as unilateral and unilateral somatic coverage. Regarding hemodynamic stability, thoracic epidural has poor. In this case, it has high risk of hypotension. Paravertebral block, erector spiny block, and serratus anterior block, excellent, they don't cause severe hypotension. In case of anticoagulation risk, epidural is high risk, strict ASRA guidelines should be followed. Paravertebral have moderate risk, erector spiny block and serratus anterior plan block have low risk. Primary indications are, in case of thoracic epidural, open, bilateral or multi-dermatomal resections. Mostly open thoracotomy, this is excellent option. In case of unilateral thoracotomy, high risk or cardiac patient, paravertebral block can be used. Erector spiny block is excellent choice in VATS and anticoagulated patient. It can act as rescue analgesia. Serratus anterior plan block can be used in lateral incisions and VATS where a deep neuraxial plan paravertebral block are contraindicated. In this patient, as it will go under VATS, erector spine block will be excellent choice. Now, core clinical takeaways are comprehensive preoperative risk assessment is the cornerstone of successful thoracic anesthesia. Optimize the patient before surgery. Employ lung protective intraoperative strategies. Multimodal regional analgesia is essential. Evidence-based multidisciplinary perioperative care improves outcome. Thank you. These are the references.
Thank you, Dr.